Tomar sus asientos. Gracias. ¿Me escucha? Good evening, everyone, and welcome to this side event on the 55th Directing Council, the high-level forum for investing for universal health, and specifically the role of public investment in health. Over the last few days, we've been listening to you, the member states, as you consider important policy documents, plans and strategies to improve the health and well-being of populations in the Americas. And we've often heard the comments during the sessions of the need for additional resources to finance those plans of actions, to finance those interventions that are required. From resilience, health systems resilience, to the arbovirus strategy, from emergency response to HIV, the issue of health financing has been central to the discussion. So this evening we've brought together a high-level panel to begin to look at this issue and to contextualize the issue of financing for health within the plans and strategies moving towards universal health. In 2014, the organization adopted a regional strategy for universal access to health and universal health coverage that adopted 4 specific strategic lines of actions: to increase access to comprehensive, quality, people-centered care, to improve governance and stewardship of the health system, to approach health by addressing the social determinants of health, and a specific line of action to improve and increase health financing. So without further ado, within this context, I would like to hand over to our director, Dr. Etienne, for her words of welcome.
Thank you, James. And before we begin, judging from the dinner that James has served us tonight, I will know where to cut in terms of the allocation, no? So thank you and good afternoon, good night. Honorable Premier Dr. Rufus Ewing of Turks and Caicos, Minister of Health of Chile, Minister of Health of Guatemala, other ministers of health, distinguished delegates, colleagues, and friends. Before we begin, I just would like you to keep in your prayers and your thoughts the peoples of the Caribbean who are now suffering the ravages of Tropical Storm Matthew, which they think it will develop into a hurricane. We can't even take a storm, much less a hurricane. So please keep these islands in your prayers. Ladies and gentlemen, 2 years ago this week, we began a journey together, a journey that will ultimately lead to the improved health and well-being of millions of peoples in the Americas through the transformation of health systems towards universal health. When you, our member states, adopted the regional strategy on universal access to health and universal health coverage, you identified a number of essential conditions that needed to be addressed to improve access and coverage for all. You noted that health can only be improved through health systems that reach out to the population and that build on primary health care embedded in local, regional, and national health services networks. You highlighted the need for improved leadership and governance in public policy development and implementation of the essential public health functions. And you noted that universal access and coverage cannot be achieved without a concerted effort in strengthening the financing of health systems. Since 2014, there has been remarkable progress in the work of member states towards universal health. Countries such as El Salvador, Panama, Honduras, Turks and Caicos, and the Bahamas have embarked on major policy reform processes with a view to expanding access. Others, such as Chile, Brazil, Bolivia, and Colombia continue to expand coverage through a concerted effort to expand integrated healthcare services. Mexico and Argentina are focusing on improving integration across subsystems, improving quality and reducing inequities. I may not have called your country's name here, but I need to assure all of you that our countries are all committed to and working towards universal health. It is also true to say that all of our countries face one important challenge. The region, and more specifically Latin America and the Caribbean, is experiencing economic stagnation and even recession. These economic conditions are projected to continue through 2017. And this situation constitutes an important threat to sustaining the achievements of member states in moving towards universal health. And it is for this very reason that we have convened this dialogue here today. In this economic climate, we have an important task ahead of us. You see, once you put your hands to the plow, you cannot take it back. The achievement of universal health necessitates an actual increase in the level of public expenditure in health. The median level is low in this region. Only 6 countries in the region have reached the benchmark of the target of 6% of their GDP for health. I am firmly convinced, even more so during times of economic hardship, of the importance of public financing in health. Evidence from Europe has highlighted that during times of economic downturn, demand for public health services significantly increases, requiring counter-cyclical investment to protect and promote the health and well-being of the population. Advocacy within government for investing in health is therefore critical in such times. But I am also convinced, and I know, and there is evidence, that there are countries who have implemented universal health care and universal health coverage that have persisted despite the fact that they were low-income countries and they were facing crisis. And Thailand is one example of this. When we talk about universal health coverage, we always mention Thailand. But Thailand did not wait until it was a middle-income country to implement universal health care and universal health coverage. It was during their economic crisis that they persisted. But increasing public expenditure in health is a difficult argument to make, to convince those that hold the purse, the Minister of Finance and even your head of state. I know this from my own personal experience. I mean, you had to dramatize the situation for the Ministry of Finance. And you want all of these things from the ceiling to fall into the open wounds of those we've operated on before you can approve a budget for us to fix the ceiling. You know, that you have to dramatize it. But I think that it's an important argument that we need to make, and it is the right argument to make. I'm also acutely aware that our out-of-pocket expenditures at the point of service remain high in our region, well above the 20% mark that was identified by the 2010 World Health Report. In those circumstances where the out-of-pocket expenditure is so high, what we see is that families have an increased risk of catastrophic expenditure in health and ultimately impoverishment. If we are committed to achieving the SDGs, to reducing poverty and improving equity while leaving no one behind, we must make a concerted effort to address the problem of charging people for health service. No, we must make a concerted effort. Now, the practice of charging people at the point of service is one of the most effective barriers to accessing health care. It is inequitable and it is an inefficient source of health financing. It exacerbates disparities between the haves and the have-nots in our society. And it constitutes an absolute no-no if we want to move towards universal health coverage. So we need to explore what are some of the different mechanisms and that we can put in place to ensure that we have some financing for health. Let me tell you, though, that even as we face important challenges in health financing towards universal health, I remain truly optimistic. I am the ultimate optimistic one when it comes to universal access to health, universal health coverage. I am optimistic because I see evidence of our member states tackling these challenges head on. Our member states are asking us, please give us technical cooperation and help us to devise the mechanisms and the financing strategies that we need to put into action to ensure that we can eliminate this payment at point of service, and that we can improve the pooling of our resources and so meet our commitments towards universal health. So I believe that we can improve access to health by improving the efficiency of our health systems as well. There is sufficient wastage in our health systems that we can recoup some of the monies and the resources that are being lost. I want to reiterate here the importance of investing in the development of integrated care services, not only in primary care services and not only in hospital services, but in truly integrated services that provide a continuum of care through the life course. By dealing with the fragmentation and the segmentation in our healthcare systems, we can improve efficiency and we can save money. I want also to reiterate also that evidence-based approaches and prioritization in the definition of services offered is necessary to improve and optimize health outcomes. The use of standard clinical guidelines across the system can reap enormous benefits while also ensuring quality of care. You go from one hospital to the next and they're using different protocols, and they're using different drugs, and some of them are using the most expensive drug. We need to make sure that we establish the mechanisms to assess and to regulate the incorporation of health technologies that can benefit the health of our people. And finally, I would like to tell you that investing in our most important resource, our health workforce, is essential if we are to achieve universal health. For too long, we have considered the health workforce as a cost to the system. They are an investment in development, and that's how we need to look at them. So we have had the recent report of the UN Commission on Health, Employment, and Economic Growth. We've had the distinguished participation of Cuba and Argentina in this, and we need to commit to investing in our health workforce, because that equals investing in health and development. So let me finish by thanking the members of the panel for participating in this evening's side event. But I want to reassure all of you that PAHO remains committed to working with you all to strengthen health systems and to promote the necessary transformation that is required as we move towards universal health. So this afternoon, I was reminded again, I had a meeting with Guatemala, and James, I was reminded again that I have asked you to draw on the experts and expertise that are in countries to form a group of experts that can give member states continued assistance in the whole concept of cooperation for health development among countries. So I'm going to push on you for that one, because there are many countries who are waiting here for health economists to come their way and to begin to help them in not just a visit now and then, but for a continuing time, so they can truly achieve. So in PAHO, we will re-examine how we are using the resources that are available to the organization, but the resources in your countries, the expertise that you have, to provide much better technical cooperation to you, so that in short time, we can move long paces towards universal health, universal access to health, and universal health coverage. Thank you for joining this. And when I go to your countries, when I visit your head of state, I always tell them we need more money for health. You're not investing sufficient in health, and that's also my commitment to you. Thank you.
Thank you very much, Dr. Etienne. I'd like to now introduce the panel. We're really delighted and honoured to have with us the Premier of the Turks and Caicos Islands, Dr. Rufus Ewing. So thank you, Dr. Ewing, for being with us today. Also the Minister of Health of Chile, Dr. Carmen Castillo Taucher. Thank you for joining us. And Dr. Ewing and Dr. Castillo will be joined by the Minister for Health of Guatemala, Dr. Lucrecia Hernandez Mac, and we have been working extremely hard in Guatemala, and we will continue to provide this support on the reform process in Guatemala moving forward. And then our own Camilo Cid, Dr. Camilo Cid, who's the Regional Advisor in Financing and Health Economics here at PAHO. So we really have a distinguished panel here this evening, and I'm going to hand over to Dr. Amalia Del Riego, who is the Unit Chief of Access and Services within the Department of Health Services and Health Systems and Services, to moderate the discussion. Thank you.
Thank you, James. La siguiente sesión de los panelistas va a tomar una modalidad de preguntas que...
And these will be common, where each will provide responses. This is not going to be your typical presentations, but rather a set of questions that are directed, and we will intersperse the questions, of course, with the answers that are received. And at the end of the session, we'll have a compilation, you see, of what is asked and what is received in terms of questions and answers received to and from the public. Panelists will have 4 minutes to develop their responses to each of the questions. A couple of them have chosen to use some slides. Others have chosen a different method. And so we will begin with the first of these.
Goes to the Premier of the Turks and Caicos, and we would like to know which policies have been developed or implemented in your country to increase public expenditure in health. Can you describe the policy? Can you also share what access problems the policy intended to address or mitigate? And can you explain what are the costs or financial impact associated to the implementation of such policy?
Thank you, Dr. Amalia. It's a pleasure to be here, and I thank you for having me at this most important forum on universal health. I will start with Dr. Etienne stated earlier that I am a true believer in universal health, both access and coverage. The Turks and Caicos Islands in 2009, in an effort to address the many health challenges, including unsustainable health financing, the rising cost of secondary healthcare services, increasing disease burden, especially with the chronic non-communicable diseases, health inequity, limited access to health for all residents, and reduced financial protection for the most vulnerable in our population. It's decided to embark upon the implementation of a social health insurance plan. This plan was designed to comply with all of the principles of social health insurance. The plan was funded through a mandatory employer-employee contribution system of 6% combined, with contributions from government as an employer, as well as government as a contributor for persons for whom government had responsibility. The National Health Insurance Plan acts as a single payer mechanism for the procurement of healthcare services for and on behalf of all of its beneficiaries. The secondary healthcare services are procured from a public-private partner who operates 2 hospitals in the islands on behalf of the government as a preferred healthcare provider. And the primary healthcare services are procured from both public and private sector on a fixed fee basis. The National Health Insurance Plan also procures secondary, tertiary level services from overseas providers, what we call the Treatment Abroad program, for all of its beneficiaries, and pharmaceuticals from private sector pharmacies. The implementation of the National Health Insurance Plan is geared towards providing universal coverage to 100% of our legally and ordinarily resident population, while undocumented and uncovered residents can access care at any public primary health care facility and at secondary care facilities in case of emergencies. The benefits of the package is extensive, with no exclusion of pre-existing conditions and limited exclusions, and all with the intent of eliminating user fees at the point of care for government-operated facilities or facilities managed on behalf of the government. So this policy initiative we see as one that sets the foundation, laid the foundation for improving and increasing healthcare coverage for all in our population, and improving access to healthcare, reducing financial risk to individuals. And it actually went beyond the basic principles of healthcare financing, which is we have extended our program to care overseas, outside of the jurisdiction, to all of the beneficiaries. And that is something that we are being mindful of and is being cautioned about, that we are currently reviewing at this moment as well to ensure sustainability.
Thank you. Y antes de
And before we continue, I simply wanted to say that we have simultaneous interpretation into Portuguese, into French, into English, and into Spanish. We have Dr. Carmen Castillo, Minister of Health of Chile, and we will address the same question, Dr. Castillo. What policies have been developed or are being planned to develop in your country that have resulted in increases in the public funding for health? Could you describe the policy? What problems in access are you dealing with? And to tell us a little bit about the cost or the financial impact of the same. Thank you. Well, as a country, first in the global context, we must point out that we're facing slow growth and with fiscal restriction, something that is very well known to many of us. In general, all the challenges that we face are common to all the other countries in the Americas that have to do with demographic and epidemiological changes, which forces us to be alert with the issue of non-communicable diseases. We have to be on the alert all the time because they do demand the use of technology, intensive use of treatments of higher cost. We're working on integrated health service networks, which has brought about greater efficiency in management. We're working hard in everything that has to do with financial protection and universalizing access to all types of benefits. Our government decided to adopt these measures, and I will simply describe 2 points, 2 important issues, which for us might be duly underscored in this context that was being mentioned by Dr. Del Riego. One is the law for financial protection for diagnosis and high-cost treatments that have to do with a law that is called the Ricarte Soto. It is in honor of a social communicator that in the year 2013 organized a march with many people requesting that health become a priority for the government in the context of high-cost medicines that they themselves, the patients, could not afford. This law began to be processed in January 2015, and it was enacted in October last year. And finally, this was a very important issue, bearing in mind, in fact, that a country for for us, having a cost of $160 million available for high-cost diseases for a country such as ours. And another issue that we'd like to underscore is investments in infrastructure that the government set for the entire country. We're talking about $4 billion for our country. That is quite significant. What has been generated ever since Dr. Bachelet took office, and this implies a huge effort in that regard. On the Ricardo Soto law, I wanted to let you know that we're saying that 11 pathologies, 11 health problems were included that receive high-cost treatment for patients. The universe of patients is increasingly growing. We started with an expectation of 4,000 people that can be benefiting from this policy and this law. And it is progressively on the rise. We have the experience of the explicit health guarantees, the GES, which have begun since 2005, and therefore we have an experience on how to approach in an orderly way access to people, clearly understanding how we will have the centers that provide the therapies and the financial protection that we wish to underscore. This Ricardo Soto is a completely universal law for the public sector, for the private sector, for the armed forces, for law enforcement forces, which is very important for us. All of this has been worked out with patients groups on a permanent basis. They hold meetings with us so that we can forge ahead on this issue. In connection with investments, I simply wanted to say that we as a government undertook to build 20 hospitals. Usually, Chile built one hospital every 8 years. This thing of building 20 hospitals, therefore, is a demand and a huge challenge. The government will leave 20 built hospitals and 20 in construction. So you will see the structure in progress and 20 besides under the different stages in papers, documents, designs, layouts in different stages of development. And to this, we have to add the fact that we're working strongly in empowering in primary education with 332 structures that have to do with family health centers, community health centers, and services to provide emergency services, high resolution for primary health care, which is not a life emergency. Therefore, the network is thus empowered. We're renewing hospitals that date back to 1906, where they didn't have and they couldn't resist a renewal with the existing structure. Obviously, we cannot build without having the necessary staff. So therefore, when you authorize an establishment, we always have to make sure that they will have sufficient manpower, sufficient professionals, and people working in the different structures. That is all. Thank you very much. And now, Dr. Lucrecia Hernandez from Guatemala, the minister from Guatemala, same question. I will repeat it. What policies have you developed or are under development in your country which will have an impact on the increase of a public budget for health? What is the policy about? What access problems are you dealing with? And what would be the cost or the financial implications of the same? Thank you very much. I would like to give you some background information as to what has happened recently in Guatemala and how that affects the health system that we currently find in the country. In 2015, several citizen mobilizations took place in Guatemala, which led to the resignation of the president and the vice president at the time, because they were involved in cases of corruption networks, which essentially were found in all government structures and at different levels. We had, in the last 4 months of the year, we had a transition government. We held general elections, which had previously been scheduled, and this year we have a new administration that took office in January this year. This administration comes in, they take office, and they find a hospital crisis. We've had crises in the past, but this is a hospital crisis as we had never seen before. We compared our Ministry of Health as a chronic malnourished child because we've had chronic lack of funding. On top of that, they get an infection, which is corruption, that drains resources from the child, both in corrupt procurement as well as in hiring a massive personnel because of political relations. And to this we add labor conflicts within the Ministry of Health, which is approximately 55,000 workers. We have 54 health trade unions. A ministry that had huge debts with suppliers as well as with their workers, cronyism, unpaid bonds, unpaid bonus, unpaid salaries. And so we have these conflicts inside the ministry, which we compare to a self-immune disease or a hospital disease. So we have a patient in critical conditions. We also understand that this hospital crisis because we have a huge backlog in the first level of service. If we start counting how many people can cover our health positions and our health centers, it turns out that this basic network of services would barely be able to cover 6.5 million people. We have 16 million people. 6.5 million people is a population that Guatemala had by mid-70s. So this means that we have a service network with a backlog of approximately 40 years. We should have more than 5,000 health positions, and we barely have 1,100 positions. That's where we stand. And after giving you this brief background, our team, the team with which we're working with the Ministry of Health, and we will be celebrating 2 months after having joined the ministry this October 1st. So we've been with the ministry for just a short period of time, but we see that there are key actions that have to be taken into account. Urgently, we need to maintain hospitals well supplied in terms of medicines and drugs, and we were able to pay the debts, and so suppliers are once again giving us the inputs and the necessary medicines and drugs. But we need to maintain basic supply, food, and the staff. These are the bare survival aspects that have to be covered in hospitals. But we also have to take measures, short-term, medium-term, and long-term. And as a friend was saying, all of these start today. And with this idea of the medium-term policy, we find the strengthening of the first level of healthcare services. And as another friend was saying, I place my bets on the position. It is a health position where we believe that this is the most basic service, closer to the community, closest to families and to individuals, and that is where we'd like to invest and concentrate our efforts. And this is what we've proposed to do. We will implement at a national level the inclusive health model, which is a model of healthcare services that intends to provide services to all individuals at different stages of their life cycle, that has a family, individual, and community program. And this is innovative, we could say, perhaps not for many of you, but for the case of Guatemala, it is, because we had one first level of service that had an excluding focus, just to put it this way, because it only gave service to children under 5 and women in fertile age. And they don't receive all the service, but cost-effective services, leaving aside many of the health problems faced by the population. And we believe that although we need to keep an emphasis on this service, we must also begin to see that there is much more population that needs healthcare services and attention by us. And this also implies that besides bringing about a change in the service model, we need to close the gaps. And even though 4,000 new health positions will not be built in the next 4 years, we do have to make the decision now and to start planning it for the coming 10 or 15 years. So we need to update things. And what does this mean? Well, it means that we do need funding for investment, and this means to refurbish existing infrastructure, build new infrastructure, equipment, equipping those health positions, and training nurse assistants, auxiliaries, and training already existent staff. This is on investment, and for that what we need is, and we already currently have loans that have not been executed for some time, some donations, and offers by international cooperation agencies. And for these first investments, this is something simpler to have supports from municipalities and the communities themselves. Now, where we find the greatest challenge is how to ensure that the budget of the Ministry of Health will increase sufficiently in order to guarantee the operation of these new health positions or the health positions where the model is simply new. And for this, we need to have a cost estimate of services and thus be able to offer a planning for the next 3, 5, 10, 15 years in order to know how to grow and implement this attention model gradually, and starting with priority municipalities on the basis of chronic malnutrition criteria, maternal mortality, child mortality, but the idea is for this to be done at a national level. Thank you.
Muchas gracias.
Thank you very much. And we now have a question for Dr. Camilo Cid, which is the following. In the current economic context, what are the policy alternatives that countries have in order to increase public investment in health? Well, first and foremost, allow me to say that in fact the region is currently quite distant from the objectives that were signed in 2014 with the universal health care coverage. Both public health, which has set the goal of 6% of GDP, as well as the reduction of out-of-pocket expenses, direct payment. Expenses reaches 4.2% in the region. That is to say, it is still far from the 6%, and out-of-pocket expenses continue to be approximately 1/3 of the total expenses in health, which is quite high. That is why in most of the countries you can see that they're located in the upper left-hand side, where they surpass 20% of out-of-pocket expenses, and they're under the 6% of GDP. Besides, as the question says, in fact, that there is an economic context which is quite complex, and we have to consider that. But before referring to that, I would like to tell you that in the estimates that we've performed here in PAHO, if we were to consider the growth that countries as an average have had, and the growth or increase in health expenditures, and if we were to project that into the future, we would have, because of the growth effect, we would attain the average objective of the region in 80 years. And there you can see on this chart, the first one in coming in would be Ecuador in 2024, I believe. I can't see from here. Nicaragua, Brazil. But some of the other countries would never made it. They would never make it, and others in 100 years or 150 years. So this is obviously an exercise that we go through, and simply to point out the urgency of this, and to say that if we don't take any concrete measures specifically in the search for a fiscal space, the objective will not be attained. Let us add to this the macroeconomic context, the current macroeconomic context with the region. For example, this year we will not grow, but we will have 8 percentage points as an average, a region that, because of that, governments have moved into a significant fiscal restriction, with a region, particularly in South America, with significant drops in countries such as Brazil, Venezuela, or Ecuador, drops in GDP. So the question is complex, but there is a response. There's an answer to this, the economic theory, and in here our colleagues, when I talk about economic theory, I speak of this in broad terms, neoclassical terms for economists. They propose that the economic policy and the fiscal policy ought to be counter-cyclical. What does this mean? Well, when the economy is on a downward trend, what the policy should do is to increase expenditure in order to produce a recovery. When the economy is in a boom, and sometimes with a danger of overheating, what the fiscal policy does is to bring down the expenditure, take advantage of covering the fiscal expenditures that would have taken place in other crises, because it is natural that the depth of the crisis is variable. This is an extraordinary crisis, particularly in Europe, where it continues to be. But the cyclical movement of the economy is something that we've known for many years in the region. And there's even a lot of studies that propose that the counter-cyclical policy of governments allowed us to attain these huge periods of human development and economic development for long periods of time. But it is also clear, and this shows that countries, low-income countries and middle-income countries, do not meet this parameter. In fact, countries that are very similar to ours, developing countries, tend to generate pro-cyclical policies and deepening the crisis. And that is not the case in Europe and in Central Asia. We have a graph on the left-hand side which shows that counter-cyclical policies in Europe and in Central Asia was carried out after the Asian crisis between 2000 and 2007. And on the right-hand side, you see the pro-cyclical policy that has been followed since 1995 in the region. 1995 and onwards. So in spite of this economic consensus that policies ought to be counter-cyclical, we see these problems emerging. Thank you, Camilo.
With Premier Turks and Caicos, and I'm trying to combine two questions in one, so that in the interest of time we can have some space for questions and answers. So the question will be, can you describe the political process for the approval and implementation of the policy, and specifically what negotiation took place and how the different positions of key stakeholders were reconciled? And also, do you have some results that you can share, particularly those related to equity in access? Thank you.
Yes, thank you. As I said earlier, the policy to, or the mandate to introduce a social health insurance program took place in 2009, but it was conceived as far back as 2006. And during that period, we engaged several stakeholders, experts in the field, partners in social health insurance, and supporters of universal health, such as PAHO. The policy and the legal framework actually was adopted from a draft provided by our neighbors in the Bahamas. And they had a draft of a policy framework for a social health insurance program, which we adopted from them. And the policy directives of the TCI government was then introduced into that policy. We also engaged the experts in the field at the time, and the engagement of the experts resulted in the formation of a group called the Caribbean Health Financing Initiative, which the first meeting was held in Turks and Caicos in 2006. And the 10th meeting of that body was actually held in Turks and Caicos this year, reflecting the 10th meeting. Several key stakeholders were engaged through the process of town hall meetings, engaged through focus group meetings with employers, employees, healthcare providers, especially those from the private sector, who tend to be the ones kind of resisting the change because it has this way of putting some kind of cap on health expenditures. And so there was resistance, but fortunately for us, our private medical sector is not as large as you will find in some countries. Most of our private medical sector is restricted to primary care. Actually, I was probably the only specialist in the island at the time in surgery, and so I shot myself in the foot by being the person who helped implementing that program. But we also had private insurance providers, because that was another important stakeholder group who, again, were interested, because when you introduce a health insurance program, then you will see whether or not this program would impact persons purchasing private health insurance. But what we found really is that that was not the case. We made a mandatory health insurance program. Those persons who could not afford private health insurance were the ones who gravitated and who were grateful for the social health insurance program. Those individuals who could have afforded actually capped their private health insurance so they can have more freedom and flexibility for what they want to do, but still contributed as mandated by law to the private health insurance program. The National Health Insurance Plan has been in operation now for about 5 years, and there has been and continue to be challenges, but we continue to strive to achieve the intended goals outlined that are outlined previously. And the most significant amendments to the plan, however, over the past few years was recently approved in our cabinet, and some other amendments will be made in our parliament during the month of October. And these will address issues such as the access issues, such as extended coverage to persons who are unemployed. Currently, the current legislation makes for those persons who are unemployed to be covered for up to 90 days. And this came at a bad time, because this policy was implemented during the time of the recession from 2008, 2009, and so there are a significant number of persons who are unemployed, and their unemployment extended beyond 90 days. So we found it necessary to ensure that these individuals are covered, to extend that coverage to as much as 18 months, but have a mechanism in place to monitor their opportunities for getting employment, and if they fall beyond that 18 months, they will then fall on another part of the plan, which is the indigent plan, which is another government-funded part of the plan. It will also address issues such as the health care to children of migrant workers, because as a policy for us, the persons who are laborers, in terms of having their children being endorsed on their work permit, was not permitted. It's not part of the law. But those same children, because of the rights of the child to education, we extended educational opportunities to those children who are there with them. And also because of the right to health, we're now extending the health care coverage to those children. And so you see us extending more and more health care coverage to migrants under this plan. We also allow for now to amend it to make voluntary contribution to the plan, because there are some gaps where there are individuals who are legally resident within the country who may be there on a long-term basis, such as those persons who decide to retire in Turks and Caicos, but they don't work, so they're not employed and they're not an employee. We find that if we were to extend coverage to those individuals, but the benefits are limited, are different. And so we will then have increased the sustainability of the plan, but at the same time improve the healthcare coverage of individuals who are in country. So with all of those particular amendments to the legislation, then we will ramp up our universal coverage to as much as 100%. Individuals. As I mentioned earlier, those individuals who are undocumented, they can access free health care at any of our government primary health care facilities, even though they're not covered under the plan. The government primary health care facilities, which is part of the program of the plan, will provide care to those individuals. The amendments, however, We'll also address risks to the plans, because with all of these things such as migrant and undocumented migrants, they all represent a risk to the sustainability of the plan and its funding. And one component that also threatens the sustainability of the plan is our treatment abroad program, where persons who come to work in Turks and Caicos, they can get care under the plan locally, but also if they would fall ill and require tertiary level treatment overseas, the plan also covers those individuals from day one of registration without even paying a red cent or their first paycheck and contributing, and will get care overseas without any capitation. So they have no limits. We find that may not be sustainable, and so some of the amendments now is to put in a waiting period, and also to put in a capitation for the overseas treatment, which is indeed not part of the principle of social health insurance, because when we speak of it, we speak of access to care locally that is available within country. Likewise, we also look at with this passage of this legislation will reduce the financial burden to individuals. There are many individuals who are indeed grateful because they have some financial protection. They would not become vulnerable to much of the financial crisis, such as global financial crisis, loss of job, etc. The plan also looked at areas in improving the care to those persons who are elderly and who are pensioners. We find that if you contribute during your productive years, during your senior years, when you're less productive, then you should be reaping from getting the benefits of the plan. So we pay particular attention to our senior citizens, those who are pensioners, and those who are vulnerable in our community. During the initial years of the operation, the National Health Insurance Plan main focus was on the procurement of secondary healthcare services, because we put it in as a financial protection mechanism and financing mechanism for government, focusing on its secondary care. But now, with all of the operations and success of the plan, we are now reorienting our focus of the plan to primary healthcare services. So we are now procuring more primary healthcare services and funding those primary healthcare programs. You will find programs such as the extended hour clinics. We find that there are a significant proportion of our population who have a challenge accessing clinics during working hours. Most clinics close at 4:30, 5:30 in the evening, and so we have extended our clinics up to 9, 10 o'clock at night. So when parents and mothers come home from work, they can take their sick children in, or they can get access to any of the government programs during those extended hour clinics. We also are looking at being more effective in the drug procurement program. Currently, the National Health Insurance Plan, as part of its drug program, will procure drugs for its beneficiaries from private pharmacies. And there's a cap on how much the beneficiary pays, up to as much as $50. The remainder of the cost for that drug is paid for by the plan. We're having a challenge in that there is no control over the costs that the private pharmacies pass on to the National Health Insurance Plan. So we are now looking for more better procurement mechanism through funds such as the Global Funds or the OECS drug program or the Jamaica drug program. We want to pool with others so that we can purchase drugs at more effective and efficient costs for our population, our beneficiary, which is very small. So it makes it more affordable to both our clients, as well as more affordable to the National Health Insurance Plan, ensuring sustainability. The National Health Insurance Plan, with all of its health and financial gains to individuals, will increase the health and productivity of individuals, and by extension will improve the health and productivity of businesses, and by extension of that will increase the health and productivity of the country with progressive increase in GDPs. And so there's no better investment than investment in universal health, because the health of the nation really is the wealth of the nation.
Thank you. I like that one. Bueno, voy a
Well, let's now move to Dr. Castillo, Minister of Health of Chile. And I'll ask her the same question. How did the political process develop for the approval of these initiatives? What were the sectors that were engaged? What was your negotiating process? And what results have you obtained thus far, or what results do you still expect to generate as a result of this policy of equity and access? Thank you very much, Doctor. Well, our political and institutional situation was quite simply that health was not a priority of government. That wasn't a priority. But the outcry of the citizenship for medication encouraged our president to move forward on the law of high-cost medicine. Now, why wasn't it part of the priorities? Well, what was absolutely front and foremost was education that was cost-free as a government. And then we tackled the tax reform, and then we tackled the constitutional reform, of course, the tax reform, in order to generate all of the reforms in whatever sector that we wanted. And then don't forget, the reform of the Constitution was because it absolutely had to be changed. What we had was dating back to the 80s, and Chile had changed a lot since the 80s. So don't forget that we'd had 2 earthquakes, 2 volcanic eruptions, 2 serious landslides, and another 2 serious forest fires that had all exerted virtually intolerable pressure on the system. Let me just give you a couple of examples. A hospital that wasn't yet completed ended up with mud in the -1 and -2 levels. Just getting the mud out was the same in cost as an entirely new consultation building. You can imagine the equipment was incredibly difficult to get. The private sector kicked in to get us the right equipment to dig it out, as it were. And so all of this pressure and this outcry, as I say, from the citizenry was such that we were compelled, I mean, literally there was no action, that we take another look at what the society itself considered top priorities. Now, generally, here are the 3 top winners in terms of priorities. We're talking health, education, and citizen security. Those are the top 3 every time. And that is what explains our decision as government. Now, let me say that the Ministry of Health, by the way, did not always agree with the imperatives. It didn't always see eye to eye with the Ministry of the Treasury. But at the end of the day, they got together, and the law came down on the side of tackling the high-cost medication. In terms of infrastructure, as I suggested earlier, we understood that there had to be a continuity from primary care all the way into the hospital care, and we were determined that each step of the way would be vetted and bought into by the Treasury so that we could get this done. Get those establishments that were focused on primary care up and running, and also the hospital. And of course, the President herself was fully committed, and there had never been in the history of Chile that many hospitals built at the same time. We're building 22 hospitals. Can you imagine? This is just never done in Chile. And by next year, there will be 36 under construction. Why? Because some of them are so complex that the building can't be done, I don't want to say overnight, but even in 3, 4, or even 5 years, because of the complexity of each of these establishments. And so, in terms of the results of our health policies, let me simply say that the high-cost medication adds up roughly to $160 million a year that's going to be earmarked for the patients, and that will grow as we develop our estimates regarding additional costs that we need to add. And civil society always has a right of opinion, and they will be able to speak up, have their views heard, and the Ministry of Health will react and see where we stand from year to year on the basis of decrees. Well, need I tell you, this is certainly not a recipe for everybody being happy. But that said, let me say that civil society is pretty wise. It turns out they're all agreed that children have to be the #1 priority. They may say, okay, I would have wanted this, I would have wanted that, but even if I'm not going to be taken care of, make sure our kids are taken care of, whether it's insulin, whether it's this or that. The choice is always, and tremendous solidarity, as it turns out, vis-a-vis the children. And so we understand that key is ongoing policy, ongoing dialogue. In terms of the hospital establishments themselves, we're renewing more than 3,000 beds in the system. We're going to have 200 critical health beds, which is important because, by the way, most of these beds do not foresee, these long hospital stays of yesteryear. They're for acute, for critical cases, and so we're going to have another 200 available to the system at large. And throughout the system, we're also very much about adding new energy, new dynamics with all these new hospitals coming up. And so I suppose it's the perfect example of the contracyclical economic posture that Don Camilo mentioned. Thank you very much, Dr. Lucrecia Hernandez. Let me turn to you. Same question again. How did the political process get underway? How did you arrive at an approval of the initiatives that you've mentioned? And what was the negotiation like? How did that work? Have you gotten results? Have you gotten expected results? And if you don't yet have them in hand, do you look forward to having them soon, and particularly with regard to equity and access? Thank you. Well, in the case of the government of Guatemala, health has been a priority. The political commitment is there. At least it's there in principle. Now, when you look at the budget, you begin to notice a few differences, a bit of a mismatch. But let me say more. In terms of the institutional policy development, we think that a good slice of the task that the Ministry of Health needs to do is to know what it wants. Once you know what you want, once you know where you're headed, that's already a huge step ahead. Then, of course, you've got to develop the means to do what you say you need. And in Guatemala, that has been easier said than done. Let me tell you, we have gone through periods, too many periods, in which in a 3 to 5 year period, we've had 3 and 4 ministers of health. How do you want to operate when you simply don't have the stability, not only at the top, but with all of that that it brings about? So again, we're clear that we need to know where we're headed, what we need to move ahead, and here we are very much backing the first level of care with this all-inclusive approach, about 12% from our first level. That's been around now for some 7 years, and we've had good results in terms of a drop in maternal mortality and mother-child mortality. And we think that this reflects universal models. And UNEDI got the WHO's Sasakawa Prize because of this particular work. So it's a model that has been tested, that is recognized, and that we are very happy to have. And we've got the technical backstopping so that we can now think seriously of implementing it as a policy. So much for what we decide needs to be done. In terms of how to get it done, again, with the political backing, we need financial backing, of course. Now that is a pretty tall order because we have, to be quite blunt, not just challenges, but frankly certain resistance that we need to overcome. Because there are other elements in the system, other actors that have their own agenda. and that we have to negotiate with in order for the ministry to be able to implement the chosen health policy. It is also true that we suffer from institutional weakness, and people get bogged down in how they do it and how it was done and don't like change. And then, as I said earlier, there is really a financing problem. The budget of the health ministry represents about 1% of GDP. 1% of GDP. Pretty low. If and when the Ministry of Finances is willing to give us more resources, we're still up against the very high obstacle. That means that tax collection is only between 9 and 10% of the GDP, and it certainly isn't a progressive tax system. Just this year, the Ministry of Finance presented a tax reform proposal, but anything that smacks of tax reform, never mind that spells it out in Guatemala, immediately raises hackles. And that was so much the case that once the proposal was presented, it was whisked away before you knew what had happened. And so we hope that this will be put back by March. Fingers crossed. However, when this tax reform was mooted, what was done was at least to try to explain how that tax increase would be earmarked principally for education, for health, and for highways. Education, health, and highways. What was not to like? And yet, the resistance was there. There was a kind of a knee-jerk resistance immediately, anything that smacked of tax reform, and that was the result. So, you asked what results we hope to obtain once this model is implemented, once that strengthening of our primary levels is effected, and in order to get the right financing. We want very much to ensure that such financing is made available, is well invested, is cogent, that we know absolutely what it boils down to in terms of salary, in terms of the purchase of medication, etc., and certainly with regard to universal access and coverage for all. This is based on 4 approaches: the perspective of health, of gender, of the intercultural dimension, and the interrelationship with the environment. And in sheer economic terms, we would hope that there'd be increased investment in health. We would hope that public financing would be better structured, looking at the out-of-pocket expenses. In Guatemala, total health expenditure is about 6% of GDP, 70%. Depending on the year, okay? It depends on the year. Somewhere between 55 and 65 or 70% is private, and more than 90% of that private expenditure is straight out-of-pocket expense. That is a huge problem, need I tell you. So we've absolutely got to improve the public expenditure in order to reduce the out-of-pocket expense to the private individuals. If we compare our situation, say, to Mexico, where the Social Security covers more than 60% of its population, Costa Rica more than 90% of the population, we in Guatemala, our Guatemalan Institute of Social Security only covers 17% of the population. So that means that it is certainly not the main source, and we have got to do better. Improve the budget, improve the coverage. Once we tackle the primary level, we hope to close that gap of those 4,000 positions in public health that we still desperately need, hoping that the health sector will improve its effectiveness, will have resolved the major issues at the primary level that, because they're left untreated, morph into problems absolutely at the secondary and tertiary level. So better access, better coverage we want, and a better correlation between the institutional health network and the community, the Mayan sources of knowledge and health. even if it isn't an integrated, because they don't want to be integrated, So we're not looking at integration with the Mayan communities, but they do want coordination. That's different from integration, particularly as regards maternal mortality, maternal child mortality, and chronic malnutrition. And we also hope that we can change the mental chip that we have. In Guatemala, people say, well, everything's private, and people look for private health care. And there's a private expenditure, but we also say that what has become private is our approach to health. And we think that that's the only way to go, and we have forgotten the great value that the public contribution could be. And we need to remember, and I'll end on this, that health is a right and not a commodity. Thank you very much. Well, thank each of you, says the moderator. Let's now open it up to a discussion in order not to tax your time. I know it's been a long day for all of us, and certainly for the panelists. Let's say we'll give us 5 to 10 minutes for questions, and then we'll give the panelists a chance to give us a last round, and then we'll move to the close. I offer the floor. Any questions, ladies and gentlemen? It's a comment, really, rather than a question, if I may. Certainly, I applaud the organization for having put together this diverse and most interesting set of group of panelists, I should say, with very, very interesting statements, each of them. In the case of Chile, I'll just say that if health was not the priority at a particular point in time, you sure have moved ahead in a hurry. 22 hospitals going up and another 18 in the pipeline is really a titanic effort underway, and I congratulate you. I fully concur with Dr. Rufus Edmonds, Your Excellency. The true capital of any country is its people, and obviously health has to be the best and most important of investments. With regard to Dr. Hernandez Mack of Guatemala, I would simply say that we are certainly with you and admire your country for bending over backwards and trying so hard to move the health sector forward. But one thing that we would like to say in terms of Costa Rica is we'd like to understand better that third sector of the citizenry. I'm talking about NGOs, about civil society. What has the Guatemalan experience been vis-a-vis civil society to move this forward? Dr. Priscilla.
Here. This is related, and what is your scheme for cost containment, both within the country and for those cases that you're sending outside of the country? But also, have you made any study on any potential catastrophic case that you might have that you would have to cover, and what would be the impact? Or if you have taken a provisional insurance for this kind of cases? I think that this is probably something that you might have in mind as to protect yourself with any of these cases. Thank you.
Señora representante de la hora.
Representative?
Sorry. We are going to take a few more questions and then we go to...
Sí, muchas gracias.
Thank you. The struggle to bring health to the population on a basis of equity and equality is very often a struggle that comes up against a central problem, which is the cost of pharmaceuticals. which puts us fully into the mindset of the corporate sector. And frankly, all of the inputs that go into it make it a very complex issue. I'm wondering what your take is on this. From my standpoint, many of the best intended efforts often are left by the wayside because it turns out that the corporate sector is pretty strong and wields quite considerable influence. So I think that institutions such as this one, Pan American Health Organization and others, should inspire us to have the courage to think through a different kind of system, one that would look at the matter with a certain amount of rationality. Sometimes you have the feeling that pharmaceuticals invent diseases in order to have an excuse to come up with new prices and new jobs. And sometimes they avail themselves of certain nomenclature in order to mix certain things and goes totally against the interests of, frankly, most every country and most certainly the poorer countries. This is a huge issue, and frankly, the pressures that are brought to bear are huge as well. The effort that has been undertaken is brave, it's ambitious in many cases, but too often, even in the best of circumstances, people give up because it's just too much and the pressure is too great. Turning to another issue, whether it's ATT or ATUPE or others, that are questioning not only the cost of products, but also the life of a patent. And we in the health sector, I think there again, have to be very clear-sighted and have a strong heart to tackle the question of the rationality of the cost of vaccines and others. We all know that together with arms, it's in the health sector that most of the most profitable business is carried out. So when we say health for all, too often we are up against these entrenched vested interests. And it's a pretty awesome thing. Very daunting, but we need to hit it head on. Thank you. Thank you very much. I certainly can't deny the floor to the Minister of Health of Ecuador, but noblesse oblige. Interpreter regrets there's no microphone, can't hear.
Hoy ya queremos estar alejados de...
We've seen enough mics. We want to stop using the mics, the gentleman says. Okay, here we go. I have a specific question, if I may, for Dr. Hernandez-Mack. You pointed out, Madam, the great weight of the private sector in the overall dynamics in the country. I'm wondering whether within your programming of this renewal and the hope that you would broaden coverage, you have any public-private partnerships? Thank you. I'd like to give the floor now to the Minister of Health of Ecuador. Yes, thanks very much. Well, quite frankly, I've had mixed feelings when I heard Dr. Hernandez of Guatemala. I remembered my own country, Ecuador, 10 years ago. And when I was hearing some of the comments from the three panelists, I had kind of flashbacks. I remembered so well why we're doing what we're doing in Ecuador. We, in the Constitution of our People's Revolution, have enshrined cost-free health care. It is a constitutional right. And when we have discussed the sustainability of the system with the president, with the head of state, he has said, look, if I had to start again, I wouldn't say it's cost-free out of the box. I would talk about a gradual increase so that you'd move eventually to cost-free. But when we're looking at GDP from 1.9, we're now at 3.8. And in the Constitution, we have 4 in terms of expenditure on health. And I've said to my vice minister, well, we've got to make the 6% because those are the economic criteria. That has to be the goal. However, when Dr. Castillo of Chile was telling us here how Chile was tackling the 20 hospitals, et cetera, and more to come, we're constructing 39. 11 are brand new, spanking new. The others are kind of remodeled. This is a huge investment. I needn't give you the price tag, but they're going to end up all looking very bright. And Dr. Cadiz Etienne has been able to see for herself how much the health profile in my country has changed. We've got 50 health centers with different diagnostic centers. We've got 40 accredited hospitals with Accreditation Canada. This is a true revolution, let me tell you, because even from the standpoint of the empowered equipment, sincerely in terms of human resources and the effort to render quality, safety, and efficiency, this accreditation means the world to us, and we're going to keep at it, not as an international accreditor, but with our own agency on safety of health services. Certainly continued to be backstopped and blessed, as it were, by Accreditation Canada, but now as a native product, as it were. And that has led us to be ever more effective. Our health centers, by the way, are not just health posts. They include actual diagnosis, typologias, including parameters such as epidemiological profiles and others, the isochrones. We have been strengthening our capacity all along, and we're now focused very much on a comprehensive public network, in bringing in the insurance, bringing in the military, bringing in the police, because we're all in the public sector, and we are all rendering primary care 80%, second and 15%, and the other in tertiary 2-3%. So that the population doesn't show up at a third level hospital because they have the flu, but the people go where they need to go at the right level of care. This has been a big difference, and it has certainly brought our costs down. It has made us more efficient. $11 is what it costs at the primary level instead of 26 or 36 at the second or third level. $11 at the first level. And certainly what the colleagues have said who spoke before me, I'm certainly not going to repeat everything they said in terms of input of technology, of medication, and so forth, because I'm very clear that if we don't fight it together, whatever you do in equipment and high technology and in resources, you're going to end up spending more than you can imagine simply on drugs. We've got a public procurement portal that has generally been very good, $300 million cheaper than we were before because of our pooled procurement on the public network. But guess what? The pharmaceuticals are at our throats, and it's an everyday struggle. Because I'm telling you, we're talking about bullying. There's a bullying at the level of the media. We're continually in the crosshairs. But never mind, we are not deterred. And we are keeping at it with the media and everywhere we go, because we know what's at stake. It's that simple. And of course, vaccination is iconic in terms of universal coverage. We had 6 biologicals in the scheme. We've now got 20 compared to Rafael Correa's first term. And we're moving right ahead, not looking back, looking forward. In terms of the population, that external population, that is people from outside our country who come to us to be treated because the treatment is free and it's quality. Well, this costs quite a lot. There are millions of dollars that are spent there without, of course, any contribution from the home countries of those people, but never mind. We want to promote the notion that prevention is key. we wouldn't have any possible way to move forward to at the tertiary level if we don't work on prevention, and there has to be co-responsibility, a sharing of responsibility by the neighboring countries, and we all need to pull in the right direction, and throughout the country indeed, at the municipalities and everywhere. I'm talking now within the country, we all understand that we've got to do our share, and the term in the local language is minga. This is a collective approach for health. And I simply ask and thank you, Dr. Carissa, for your leadership and that of the whole of PAHO. We have got to keep the needs of our countries very much in mind, and let's keep working at improving our teams to save money, working from the grounds up, so that we see a way forward and not keep asking or expecting money from the state, but try to find innovative ways out of the box to see how we can reach universal coverage and access for all, because certainly that is our aim, and we want to be able to offer these services cost-free for everybody. We have 10 years experience under our belt, and let me tell you, there's no question that the people of my country are happier, they are proud of what we've done. The self-image is great, and that's what comes from this kind of work.
Thank you. I believe that I can tell what the energy that we have left at this late hour is. I will not give the floor for additional questions. I believe that we have 2 additional days of the Directing Council, and during the breaks we can continue with the dialogue. But I do want to give a possibility to our distinguished panelists if they have any last comments to make very quickly. 1 minute each so that we can bring this to an end.
Panelists to give us a last word, 1 minute. Honorable Premier, you go first.
Sorry, I thought I had a question to answer, but in answering that question, I think what I would say, his question was, how do we deal with cost containment for local care and overseas care? The best thing that we can do for cost containment is to reorient our focus and invest in primary care that will result in reduction in complication to lead to secondary and tertiary level diseases. So the best you could do for cost containment is to invest in primary care. However, locally we have a fixed performance-based contract that is, and also with our secondary care, we also have a performance-based, disease-specific performance-based contracts initiative that we're working on now that will also help to reduce, improve primary care and have cost containment. But as it relates to catastrophic care for the overseas treatment, we actually have a reinsurance program for catastrophic care, and we have better procurement services. We have shifted our procurement from predominantly US-based to more cost-effective Caribbean-based healthcare. That has actually resulted in us, our expenditure was $40 million in 2008 for 28, for 10,000 individuals. And in 2015, we're spending $10 million on 28,000 individuals. All right, and so that has resulted in a significant cost saving and cost reduction and cost containment to make sure that the program is more sustainable.
Thank you. Dr. Castillo.
Dr. Castillo, please. Very briefly, simply to point out that as a government, aside from the fact that it was not part of Line 1, this issue of health, this government has always believed that health is a right, and therefore all beneficiaries of public health are for us extremely important, and we should move forward in everything that has to do with giving quality and dignity in healthcare. I will read out the phrase that this social communicator drew up when we drew up the Ricardo Soto law because of the name of the person who made this appeal. I am making this appeal on behalf of the sick people today and those that are coming in the future, and not only because of those that are sick with cancer, but all those that have strange, odd diseases, and those that are called catastrophic. This is what he said, and I simply wanted to leave these words with you as a seal, as a stamp, and that is why this has led to our president to come up with a law in 10 months. Thank you. Thank you very much, Dr. Hernandez. Now, in connection with the experiences that we've had with the non-governmental organizations, we should point out that on the basis of the health reform that we had in Guatemala in the mid-90s, the program that was spearheading that reform process was the Coverage Extension Program, which had to do with entering into agreements with NGOs, historic, many of these at the beginning NGOs that had been in existence for a long time and had quite an experience in working with the communities. And we entered into these agreements precisely to provide a basic mother-child care once a month with roving equipment that visited the communities once a month. Ambulatory equipment. So this program of coverage extension would have been a good idea if this had been considered as a temporary thing, establishing this program in the meantime while the regular network of services was strengthened. However, it remained in time. It continues to be installed. It is there. We never considered an end to this, and it was deteriorating to the extent that problems in management and disbursements to NGOs led to many of these historic NGOs withdrawing, leaving, and others such as congressmen and other people with certain powers were creating their own NGOs simply to be able to get a hold of this public finances. So the corruption created a great deterioration in the program, and it was never able to prove results in improving the health conditions. But this corruption problem ultimately led us to deciding to put an end to all agreements. And thus, and also because of a lack of budget, in 2015, we put an end to this program of extension of coverage. So the experience has not been very good. Now, in connection with the relation in general with the Ministry of Health, or how we see the private sector, what we see in Guatemala is that our health system is private because of omission by the state. So we never had a strong state that could be privatized, but we simply had an absence of the public, and therefore this has flourished, the private, for-profit, as well as community organization and society in order to create NGOs or foundations which will enable them to meet those needs. And the Ministry of Health, although they've been weak in their role as the provision or the care, they've also been very weak in their function of regulation. So we believe that there must be a strengthening of the public institutionality, both on the provision of services as well as on regulation, to be able to generate better relations between public and private. Thank you. Thank you very much. Dr. Sid? Yes, very briefly. Please let me tell you that what we have as lessons in our process in being able to attain these goals that we've set. Well, first of all, we know, and several studies have been conducted in the region, and more or less we can tell you that there is a fiscal space that essentially has two sources, two main sources. One that has to do with taxes directly, but essentially within taxes, it has to do with taxes on health risks, that is to say, tobacco and alcohol, and also in what is known as tax exemptions, which at times are late and are the result of very old age policies that could be redirected to the health sector. And the other major source of fiscal is the efficiency of the expenditure that is already being executed. There's a huge mystery, but we do know, and this is what is recommended by PAHO's strategy, is that on the one hand, policies lead to segmentation, that is to say, do away segmentation of the systems, which usually entail structural reforms and other important transformation of systems, and they also lead to increases in efficiency. But there's also another aspect, faster, speedier, more at hand of gains, efficiency gains that they resort to, and that essentially have to do, once again, with the two main aspects. One, the mechanisms for the allocation of resources, procurement mechanisms, the incentives produced therein, incentives with a payment per results on allocation, a whole gamut of issues that could be implemented and that could be achieved. Secondly, we were mentioning the purchase of medicine, centralized purchase, access to common purchase funds such as Bajos Fund, and also these same criteria for the application of scale economies in the countries, which also yields and reaps good benefits. So thank you. Thank you very much. I would like to thank our panelists for their excellent approach and their excellent presentation of these issues. To thank our participants, I'd like to ask for a big round of applause for our panelists. And to also thank our director for presenting here three experiences, three very different experiences, but with very clear elements on what has to be done in order to move forward towards universal health care, and specifically to see how it is possible to increase public expenditure in health, and that there are solutions. So we're very optimistic in saying that we do have solutions. And with that, I give the floor to Dr. Fitzgerald so that he can officially bring this activity to an end.
And just to reiterate our thanks to the panelists. I think we've seen three amazing experiences. One, a small island nation, from the Premier, from the head of state, based on a social health insurance system. The experience of a middle-income country, Chile, and a specific focus on a very important law, but from the perspective of an integrated health systems approach. And then the context of Guatemala, who is embarking on a reform and really a change of culture towards public health and universal access to health and universal health coverage. I think these have been extremely important to present for you today. I think that really is one of our principal roles here, is to share these experiences with you and to promote the necessary dialogue between countries in this area, and that is something that we will do. I think one of the key messages, there are two key messages I think that we've taken from this. One is that it's not only the Minister of Health or even the health sector that will essentially impact the level of health financing that the health sector needs. The dialogue needs to occur across government, with ministers of finance and with heads of state. And I think this is an extremely important message. Second, irrespective of the types of health systems we've seen, we need to perhaps look at the health financing functions: collection, pooling, and allocation, and to begin to look at each of these three areas to see how we can optimize and improve on each of these areas independently of the discussion of the model, the organization model. Finally, we remain at your disposal to provide the necessary technical cooperation. We do have a network of economists that can be brought to bear with the policy advisors that can be brought to bear across in the delivery of technical cooperation. And this is an extremely important resource, because we see that there is an enormous demand in the countries at the moment for technical support in health financing and health economies. But all of that needs to be clearly oriented towards the specific health objectives of the reform processes within the countries. So we cannot separate the discussion of health financing from the direction of the discussion around the health reform. Thank you very much.